morning all. Last class we were discussing regarding the stroke, and up to the pathophysiology we have discussed already. And next we are going to the clinical manifestations. Depending upon the arterial occlusion, there will be different manifestations. And first we are seeing the clinical manifestations of specific cerebral artery involvement. In that, the middle cerebral artery involvement. Once the middle cerebral artery is involved, there will be blockage of the main stem, and there will be resultant contralateral paralysis or the hemiplegia, and contralateral anesthesia, loss of proprioception, fine touch, localization. Then dominant hemisphere, there will be aphasia on the dominant hemisphere, and once there is involvement of the non-dominant hemisphere, then there will be neglect of the opposite side and the dysmetria, then homonymous hemianopsia and conjugate gaze paralysis. These are the main manifestations in the middle cerebral artery involvement. The contralateral paralysis means once there is a right side involvement, there will be manifestation on the left side of the body. As you all know, our right side of the brain will be controlling the left side of our body, and there is a contralateral paralysis. Then coming to the anterior cerebral artery involvement. Once there is involvement of the anterior cerebral artery, then there will be occlusion of the stem, then occlusion distal anterior communicating artery, contralateral sensory and motor deficit of foot and leg, then contralateral weakness of the proximal upper extremity, urinary incontinence possibly unrecognized by the patient, then apraxia, then personality changes, flat effect, loss of spontaneity and the destructivity, and the possibly cognitive impairment will be there. These are the main things in the anterior cerebral artery involvement. Then coming to the posterior cerebral artery involvement, there will be thalamo-geniculate branch occlusion, then there will be contralateral sensory loss, temporary hemiparesis, homonymous hemiparesis, paramedian branch occlusion, central, midbrain and thalamus. These are the things in the posterior cerebral artery involvement. Then once there is involvement of the vertebrobasilar artery involvement, the bilateral motor and sensory deficit of the all the extremities will be there. Means both the legs and both the arms will be getting affected. Ipsilateral Horner syndrome, then meiosis, ptosis and decreased sweating will be there, and hoarseness, dysphagia, nystagmus, diplopia and blindness, then nausea and vomiting and ataxia. These are the main things in the vertebrobasilar artery involvement. Mainly there will be getting all the extremities will be getting affected. That is a main point, the vertebrobasilar artery involvement. Then clinical manifestations of the TIA or the transient ischemic attack. There will be symptoms related to specific carotid artery involvement, and the visual disturbances will be there, that is temporary blindness in one eye or the blurred vision, then motor disturbances, that is hemiparesis, localized motor deficit in face and extremities, then sensory disturbances, hemianesthesia and loss of sensory deficit in the ipsilateral side. These are the things in the manifestation of the TIA. Then the symptoms related to vertebral involvement is motor disturbances, then visual disturbances, then other brief lapses in the level of consciousness, that is sensory disturbances, dizziness, vertigo and the tinnitus. Then the common symptoms means depending on the systemic effects, that is motor related symptoms, then bowel and bladder, then language, sensory perception and the cognitive emotional. You can see one by one. That is, one is motor, that is hemiparesis or hemiplegia of the side of the body opposite the site ischemia, initially flaccid and then progressive to spastic type. Then dysphagia, that is swallowing reflex may also be impaired. The swallowing reflex will be impaired. Then dysarthria means speech problem, that is impaired vocal ability will be there. That is the main things in the motor, that is hemiparesis or hemiplegia of the side of the body opposite the site of ischemia, then dysphagia and dysarthria. Then coming to the bowel and bladder, there will be frequency, urgency and urinary incontinence will be there, and the constipation will be related to more to immobility than to physical effects of stroke. Means not because of the physical effects, but because of the immobility, there will be chance for constipation in case of a stroke patient. Then language, in language there will be non-fluent aphasia, that is also known as the motor of expressive aphasia, that is difficulty or inability to comprehend the speech. Then the fluent aphasia, or the also known as the sensory or receptive aphasia, that is difficulty or inability to comprehend the speech. Then alexia, that is inability to understand the written words. Then agraphia, that is inability to express self in writing. These are the things in the language problem. Then the sensory perception, there will be diminished response to superficial sensation, diminished proprioception, then visual defects, decreased acuity, then diplopia and homonymous hemianopsia, visual changes, perceptual deficits, unilateral neglect syndrome, then apraxia, inability, then constructional inability, then agnosia, anosognosia, then spatial relationship, that is loss of ability to judge the distances, size or localized objects of space, and impaired right side discrimination. Then loss of proprioceptive skills, that is what is the position of our body with respect to the environment will not be perceived by the patient, that is the inability to the disturbance is the proprioception. Then the unilateral neglect means once we are staying in the right side of the patient will not be responding to the, once we are asking any question from the right side of the patient will not be responding, and once we are in the opposite side or the left side, then the patient will be responding. That is a unilateral neglect. One side will be neglected by the patient. Then the cognitive emotional, that is emotional liability and the unpredictable behaviors may be socially inappropriate, that is crying, jacks and jeering will be there. Then depression, memory loss, short attention of span, early distractibility, then loss of reasoning, judgment and abstract thinking ability will be there. Then specific deficits after stroke, that is mainly the hemiparesis or hemiplegia, then aphasia, dysarthria, dysphagia, apraxia, visual changes, and the homonymous hemianopia. These are the specific deficits after the stroke. Then Horner syndrome, then agnosia, unilateral neglect, then sensory deficit, then behavioral changes and the incontinence. Then coming to the diagnostic evaluation. Mainly the diagnostic evaluations include the history collection. Means we have to rule out whether the patient had developed any specific clinical signs, which are whatever we have discussed, and what about the risk factors of the patient, and what is the possibility of having a stroke to the specific patient, that we have to identify from the history collection. Then coming to the physical examination, means we have to look for the paresis or the hemiplegia or the weakness of the particular body with respect to the history and all. Then we have to go for the CT brain, then CT angiography, then MRI brain, then angiography, then transcranial Doppler, then lumbar puncture and the EEG. These all are the specific tests we have to rule out the specific stroke. Means once there is a stroke, which artery is involved and what we have to do, that we have to rule out with the assistance of the CT brain and angiography and all other investigations. So these are the main diagnostic evaluations of stroke. Then coming to the collaborative care. Mainly we are dealing with the drug therapy, that is we are using the tissue plasminogen activator, and the indications are the case diagnosis within 3 hours, then MCA 1 out of 3, and age greater than or equal to 18 years, and by patient consent. These are the relative consent. These are the main indications. Then the contraindications are BP more than 185 or 110, then platelet count less than 1 lakh, glucose less than 50 or more than 400, then prior stroke or head injury within the 3 months, then minor stroke symptoms, then recent MI, then coma or stupor, GI bleeding within the 21 days, and major surgery within 14 days. These are the specific contraindications for the use of tissue plasminogen activators in case of a stroke. The tissue plasminogen activator is the emergency management or immediate care what we are doing in case of a stroke. That means we will be inserting the specific medicine into the patient body in order to reduce to improve the thrombolysis. That is the use of tissue plasminogen activators in case of a stroke. Then coming to the surgical management, mainly we will be opting for the carotid endarterectomy, then angioplasty and stents. Means in case of a CAD or the coronary artery disease, we will be using the stent and all. The same like that in this case, in the case of the brain attack also we can use the stent, and through that we can dislocate the ampulla and we can make the pathway clear by using the specific stent. Then the surgical blood vessel repair may be doing, and surgical clipping means we will be using the clip just like a clip. We will be using the surgery to insert a clip to the cerebral circulation, and through the clipping we can encourage the proper circulation to the body. Then coiling. The coiling means we will be doing the coiling of the cerebral artery in order to improve the circulation. Then surgical AVM removal. That is if there is any malformation, arteriovenous malformation is there, then we can remove it surgically. That is the surgical AVM removal. Then the intracranial bypass means just like the coronary bypass, say the same just similar to that itself, we will be bypassing the specific arterial circulation to the specific portion of the brain by using a bypass, or grafting will be doing, and we can maintain the proper circulation. Then the stereotactic radiosurgeries. These are the main surgical options which we are using for treating the case of a stroke. Then the complications in relation to the stroke are deep vein thrombosis, pulmonary embolism, aspiration pneumonia, then spasticity, joint contractures, then post-stroke depression, then recurrent stroke, bed sore, hospital-acquired sepsis, and the urinary tract infection. The deep vein thrombosis because of the immobility of the patient, and once the patient is confined to bed for a long period, there will be chances for deep vein thrombosis unless we use any precautions to prevent the case. Then the pulmonary embolism, once the patient develop the DVT, then there will be chance for dislocation of the ampullae, and it may lodge into the pulmonary circulation, that may lead to the pulmonary ampullae formation. Then aspiration pneumonia, once the patient is in the case of a stroke, the patient may be having the difficulty in swallowing and all, and once because of that there will be possibility for aspiration pneumonia. By using the NG tube as a feeding, we can prevent the risk for aspiration pneumonia. Then the spasticity, then there will be muscle spasticity because of the stroke. That is the spasticity. Then joint contractures will be there. Then post-stroke depression, then recurrent stroke. Once the patient is having the primary stroke, then there will be chances for further stroke also. Then bed sore because of the case. In such cases, the patient will be bedridden, and that may lead to the bed sore formation. Then the hospital-acquired sepsis because of the invasive and other procedures, there will be chances for HS, that is hospital-acquired sepsis. Then